Hello everyone, my name is Matthew Davis and I'm an infectious disease clinical pharmacist at UCLA Ronald Reagan Medical Center. And today I will be discussing Remdesivir, a review of pertinent drug information for SARS-CoV-2, which is the virus that causes COVID-19. Mechanistically, Remdesivir is a nucleoside analog that exerts antiviral activities through two known mechanisms. First, it interferes with viral RNA-dependent RNA polymerase, leading to delayed termination of RNA transcription. Additionally, it is preferentially incorporated into the mRNA template strand over endogenous nucleotide bases, which interferes with complementary base pairing for replication. It was granted full FDA approval on October 22, 2020, and it is formulated for intravenous use, but inhalational formulations are under investigation currently. For dosing in adults, there is a 200 mg load on day 1, followed by 100 mg daily thereafter for a duration of 5 to 10 days. The dosing used for pediatrics is a 5 mg per kilogram load, followed by 2.5 mg per kilogram daily thereafter. Examining the molecular structure of remdesivir, it is a monophosphoramidate 1'-cyanoceadenosine nucleoside analog, and I'd like to highlight a few key points about its structure-activity relationship for you. First, let's take a look at the monophosphoramidate group. So here are three examples of a C-adenosine nucleoside analog with various 5' carbon substitutions circled for you. On the left, we have the hydroxylated form, which in order to be activated requires phosphorylation by intracellular kinases. The issue here is these nucleoside analogs must compete for phosphorylation with the endogenous nucleoside pool, and this is a rate-limiting step for activity. In the middle, we see the monophosphate form, which circumvents the need for initial phosphorylation, but this phosphate group is negatively charged, which impacts its ability to traverse cellular membranes. The phosphoramidate moiety on remdesivir mitigates both of these concerns. First, the substitution is neutrally charged, so there's no impact on membrane permeability. Additionally, once intracellular, the molecule is cleaved by esterases and converted to the monophosphate form, which circumvents the rate-limiting initial phosphorylation step. Next, I'd like to focus on the 1' cyano modification. So when the paired C-adenosine molecule was tested in vitro without any modification, it demonstrated very poor selectivity and was highly cytotoxic in the cell lines under study. But when the 1' position was modified to incorporate a cyano group, it conferred high selectivity for the viral RNA polymerase active site, which led to significant improvements in selectivity index values. For remdesivir pharmacokinetics, remdesivir is 12.1% unbound to plasma proteins and distributed widely throughout the body. For metabolism, the phosphoramidate prodrug is cleaved by esterases and carboxypeptidases intracellularly. Drug excretion studies have yielded recovery in urine, mainly as a nucleoside metabolite, or GS441524, with partial excretion in feces. And a few key points on pharmacokinetic parameters. The prodrug phosphoramidate compound is rapidly converted to the nucleoside metabolite, which peaks at around 3 to 4 hours. This metabolite has a relatively long half-life of around 25 hours. For safety information, remdesivir was well tolerated in multiple dose phase 1 clinical trials. The most notable adverse event reported is transaminitis, with an onset ranging from 5 to 25 days and resolution occurring 3 to 47 days thereafter. This led to the development of transaminase-based exclusion criteria for clinical trials. Other adverse events that have been observed include infusion site reactions, gastrointestinal events including nausea, constipation, and dyspepsia, and headache. Remdesivir does include a cyclodextrin solubilizing agent with either 6 grams or 3 grams per 100 milligrams of remdesivir vial based on the solution or lyophilus powder formulations respectively. To compare, a 400 milligram voriconazole dose of intravenous voriconazole would contain 6.4 grams of cyclodextrin. However, it is widely accepted that this amount of cyclodextrin exposure is of minimal clinical significance based on historical experience with voriconazole and the relatively short course of remdesivir. Arguably, the most notable characteristic of remdesivir is its broad and potent antiviral properties against a wide array of RNA viral families. Focusing specifically on coronaviruses, remdesivir possesses submicromolar EC50 values against human and zoonotic coronaviruses, including MERS-CoV, SARS-CoV-1, and SARS-CoV-2. I'm going to be focusing on its activity against these three viruses specifically. So one explanation for the broad activity against numerous genogroups of coronaviruses is the highly conserved nature of the NSP12 enzyme, or the RNA-dependent RNA polymerase, which is the viral target for remdesivir. This is shown in the figure on the left, where we can see an upwards of 90% homology across viruses, approaching identical sequences with certain combinations. This is in direct contrast to the genetic variability in spike proteins, which are used for host cell entry. We can see on the right where shades of red represent homology of lower than 50% across viruses, which represents high diversity and allows viruses to target receptors in their respective host species. Next, let's look further at antiviral activity. Now, since the majority of us are not virology experts, and this past year is probably the first time we've ever encountered some of these terms, I'd like to define them briefly for you. The EC50, or effective concentration 50, which in this case is the concentration required to produce half maximal inhibition of virus yield and viral replication, is a parameter for potency. The CC50, or cytotoxic concentration 50, is the concentration required to produce 50% cytotoxic activity in the cell lines under study, which correlates to toxicity. The selectivity index is a ratio of the two concentrations, with CC50 being divided by EC50, with a higher ratio in this case for Remdesivir, representing higher selectivity for viral polymerases. Looking at in vitro activity of Remdesivir, it has sub-micromolar activity across SARS-CoV-2, SARS-CoV-1, MERS-CoV, and Ebola, with relatively high CC50 values. And this translates to high in vitro potency against these viruses and maintaining high selectivity for viral targets. So this is in contrast to other agents that were being explored or that were explored for SARS-CoV-2 activity, like the nucleoside analogs ribavirin, penciclovir, and favipiravir, which all have relatively high EC50 values. Notably, Remdesivir is more potent in human airway epithelial cells than in previously tested Vero E6 cells or African monkey kidney cells, which is driven by differences in cellular metabolism and efficiency of conversion to the active triphosphate form. We can see that the human airway epithelial cell line generates higher levels of the active form and has a considerably lower EC50 value as demonstrated by plaque assay here. So why do the other nucleoside analogs have seemingly poor in vitro potency? Well, during RNA transcription for coronaviruses, there is a proofreading process that is facilitated by an exonuclease enzyme. For nucleoside analogs, this translates to being removed from the RNA transcript, leading to decreased activity. However, it appears that Remdesivir is able to maintain activity despite the exonuclease through two properties. First, because the nucleoside base has a 3' hydroxyl group intact, it allows for chain elongation. Typically, 3 additional base pairs are added prior to terminating replication. These additional bases provide protection from exonuclease excision for Remdesivir. Secondly, Remdesivir is incorporated preferentially over endogenous nucleoside bases in SARS-CoV, SARS-CoV-2, and MERS-CoV. So even if it were removed via proofreading, it would be more likely to be preferentially reincorporated downstream. Despite these properties, Remdesivir's antiviral activity is impacted by the presence of the exonuclease enzyme. As demonstrated in these two graphs, wild-type virus, denoted by the black line, required about a 4-fold higher Remdesivir concentration to produce an equivalent drop in viral titers or in viral inhibition compared to an exonuclease knockout viral strain. However, this is a modest impact on activity compared to that seen with other nucleoside drugs. So let's take a look at animal data. For SARS-CoV-1 in a murine model, prophylactic Remdesivir achieved significant reduction in viral loads, prevented decline in pulmonary function, reduced pathologic changes including intraalveolar edema from diffuse alveolar damage, and improved survival compared to vehicle-treated controls. Similarly, in a MERS murine model, and also in rhesus macaques, prophylactic Remdesivir conferred significant reductions in viral titers, improvement in clinical scores, reduction in observed lung pathology, and significantly improved survival in the murine model. The macaques were euthanized at a pre-specified date, so survival effects could not be determined. For treatment of SARS-CoV-1, Remdesivir showed reduction in viral titers, improved clinical and pathologic criteria, but survival benefit was only observed with initiation on day +1 of illness and on day +2, highlighting the potential importance of early initiation of therapy. In MERS, virologic, clinical, and pathologic benefit was observed in treatment in both murine and macaque models, but survival benefit was not demonstrated in the murine model. For Ebola in a macaque model as well, improvement in virologic, clinical, and pathologic endpoints was observed, but survival effects could not be evaluated. More recently, Prugers and colleagues engineered a chimeric SARS-CoV strain encoding the SARS-CoV-2 RNA polymerase and treated infected mice with Remdesivir, which reduced viral loads and improved pulmonary function compared to vehicle-treated controls. So next, let's move on to clinical data. Looking at the randomized clinical trial conducted at 10 hospitals in Wuhan, China, published in The Lancet, the trial included patients with severe COVID-19 defined as pneumonia, hypoxia, or a PF ratio of less than 300. 255 patients were screened and 18 were excluded, 14 of which were deemed ineligible and 4 which withdrew from the study. 236 patients were enrolled in the final sample, which is considerably lower than the trial's target enrollment of 453 patients due to the study being terminated early due to control of the outbreak. Patients were randomized in a 2-to-1 fashion to remdesivir or placebo, with 158 patients in the remdesivir intention to treat population. Of these patients, 3 received no doses of remdesivir and 5 received shorter than 5 days of therapy, leaving 150 patients in the per protocol population, or 95%. The median age for patients was 65 years, with an interquartile range of 56 to 71. Patients were predominantly male, making up around 60% of the sample. Oxygen requirements at baseline were nearly universally low-flow nasal cannula, making up around 80% of the sample, and the median NEWS2 score at baseline was 5 and 4, corresponding to a moderate and low risk severity of illness, respectively. Median duration of symptoms prior to enrollment was 10 days, with an interquartile range of 9 to 12 days, and the majority of patients had coexisting conditions at baseline, with the most common being hypertension, diabetes, and coronary artery disease. The primary endpoint for this trial was time to clinical improvement, defined as a 2-point reduction in the 6-point ordinal scale listed on the left, which is identical to the one used for the compassionate use case series that was previously published in New England Journal of Medicine. For the primary endpoints, there was no significant difference detected in the reduction in time to clinical improvement between remdesivir and placebo. The median times to improvement were 21 and 23 days, respectively, with a corresponding Cox proportional hazard ratio of 1.23 and a 95% confidence interval of 0.87 to 1.75. Examining time to clinical improvement solely in patients that initiated therapy within 10 days of onset of symptoms, there was a larger numerical reduction in time to improvement with the increased Cox proportional hazard ratio of 1.52. Now, although this is in line with our expectation that benefit is optimized with early initiation, subgroup analyses like this must be interpreted with caution and should be truly only used for hypothesis generation and not confirmation. No significant difference was seen in 28-day mortality. Looking at a few other analyses of interest, on the left we can see the Kaplan-Meier curves for time to clinical deterioration, defined as one category increase in the ordinal scale or death, which demonstrated no appreciable difference between patients receiving remdesivir therapy or placebo. The same similarity between arms was observed in the quantitative viral load curves depicted on the right. No new safety signals were identified in this study. There was an overall low rate of discontinuation due to adverse events, with 12% of patients in the remdesivir arm and 5% in the placebo arm. There was a notably low rate of transaminitis in the study. So, key take-home points from this study. First, it was a placebo-controlled randomized trial, providing high quality of evidence. Overall, this was a negative study for remdesivir and should be treated as such, with the understanding that sample was ultimately underpowered for the primary endpoint. Remdesivir did not significantly reduce time to clinical resolution. There was a potential signal that patients initiating on therapy earlier might benefit more, which is biologically plausible, but must be interpreted with caution. Importantly, there was no difference observed between groups in time to deterioration, 28-day mortality, viral load reduction, along with numerous other secondary endpoints. For safety, remdesivir is well tolerated compared to placebo, with an overall low rate of discontinuation. Next, we have data that were very highly anticipated, the final results from the Act 1 trial, which were recently published in the New England Journal of Medicine. These results represent Phase 1 of the adaptive COVID treatment trial, which is an adaptive, double-blind, placebo-controlled randomized trial. In this first phase, it was structured to compare 10 days of remdesivir to placebo for COVID-19 of varying degrees of severity. 1,114 patients were assessed for eligibility. Of these, 52 were excluded, leaving 1,062 patients to be randomized in a 1-to-1 fashion to remdesivir or placebo, with 521 patients in the placebo arm and 541 patients in the remdesivir arm. Patient characteristics were well matched between groups. The median age for patients was around 59 years for both groups. Patients were predominantly male, making up around 2/3 of the sample. And median duration of symptoms for both arms was 9 days, with an interquartile range of 6 to 12 days for remdesivir. For baseline clinical status, the most common baseline category was Category 5, or patients requiring low-flow oxygen supplementation, making up about 40% of patients in both arms. This was followed by Category 7, or patients requiring mechanical ventilation and or ECMO, which comprised 23% of the Remdesivir arm and slightly more in the placebo arm at 28%. Importantly, analyses stratified for baseline clinical statuses were conducted to even out the slight differences between arms and baseline characteristics. The primary outcome was time to clinical recovery, which was defined as Category 1 through 3 on the 8-point ordinal scale on the right. These were patients that were discharged with or without limits on their activity, and patients that remained hospitalized but were no longer requiring ongoing medical care, primarily kept inpatient for infection control purposes. For the primary outcome, Remdesivir significantly reduced time to clinical recovery with a median time of 10 days versus 15 days for placebo and a rate ratio for recovery of 1.29. An analysis adjusted for baseline clinical status demonstrated nearly identical results with a rate ratio of 1.26. Below you can see the Kaplan-Meier curves for both arms, which show a consistent separation that appears to begin within the first week of therapy and persists throughout the follow-up interval. The authors conducted several pre-specified subgroup analyses to attempt to further pinpoint which groups benefit from Remdesivir therapy. The significant benefit that was seen in the patients presenting with symptoms for greater than 10 days from the preliminary report was not observed in the final report. It is important to note that the confidence interval for these analyses were not adjusted for multiplicity and as such cannot be used to infer treatment effects. Here we have recovery Kaplan-Meier curves broken down by patient baseline category. Looking at these figures, we can see the most apparent separation between arms was observed in patients who required low-flow oxygen supplementation at baseline. A few quick points to highlight here. First, we can see the confidence intervals were much wider in the other groups because these other groups were smaller than the low-flow group. Despite this, there is a demonstrable lack of benefit observed in the high-flow and mechanical ventilation groups, with curves overlapping throughout the interval. This figure is a graphical representation of day 15 clinical status broken down by baseline category. Categories are represented with a color spectrum, with the leftmost categories in shades of red representing worse outcomes, and conversely blue shades on the right representing better outcomes. I think the most meaningful information that can be taken away from this figure is the proportion of patients who worsen from their baseline to day 15 clinical status, so I've highlighted those rates for you. In the ambient air group, the proportion of patients that worsened was 8.3% for Remdesivir versus 15.7% for the placebo group. A larger separation was seen in the low-flow group, 10.4 versus 23.6%. This narrowed slightly with the high-flow group with 30.5 versus 36.7%, and virtually disappeared in the mechanically ventilated or ECMO patients with 10.7 versus 13.6% of patients worsening from their baseline status to their day 15 clinical status. Looking towards mortality outcomes, in the overall population, there was a non-statistically significant reduction in mortality between Remdesivir and placebo, with the Kaplan-Meier estimates for mortality being 6.7% versus 11.9% at day 15, and 11.4 versus 15.2% at day 29, respectively. Examining the low-flow subgroup, we can see a clear separation between the two curves, suggesting a potential protective effect in this subgroup of patients, which requires further exploration. Remdesivir was well tolerated in the study compared to placebo, with higher rates of adverse events being observed in the placebo arm, which highlights the high morbidity of the underlying disease process. Notably, acute kidney injury occurred at similar rates between arms, and transaminase elevations were observed more frequently in the placebo arm. So wrapping it up, the final report for the ACTT-1 trial, or the ACT-1 study, was largely consistent with the preliminary report. Remdesivir significantly reduced time to clinical recovery, making it the first proven therapy for COVID-19 and garnering it the standard of care designation in the process. This benefit was similar in the baseline adjusted analysis, and recovery was most apparent in patients beginning in baseline category 5. Whether this was due to relatively higher enrollment in this baseline category or simply these patients benefit most from Remdesivir therapy is still yet to be determined. As mentioned previously, there was no benefit observed in patients who required mechanical ventilation or ECMO at baseline. This is complicated by the potentially inadequate follow-up duration for this subset of patients. Significant benefit was observed in the subgroup of patients presented with 10 days or less of symptoms, and not for those presenting with greater than 10 days of symptoms, but this requires further confirmation considering the subgroup analyses were not adjusted for multiplicity. For mortality, there was no statistically significant reduction in mortality observed in the patients overall. There was lower mortality observed in the Remdesivir patients from baseline category 5 in this report. However, this requires further confirmation. For safety, remdesivir was well tolerated overall and had a lower adverse event rate compared to the placebo arm, primarily owing to higher rates of respiratory adverse events in the placebo group. This next trial, referred to as the Simple 1 or the Simple Severe study, was the Gilead-sponsored trial comparing 5 versus 10 days of remdesivir in COVID-19 patients with an oxygen saturation of 94% or lower on ambient air or a supplemental oxygen requirement. Patients requiring mechanical ventilation or ECMO or those experiencing multi-organ dysfunction were excluded. 408 patients were screened, 11 were excluded or did not receive treatment, leaving 397 patients who were randomized and started therapy. 200 in the 5-day group and 197 were in the 10-day group. I would like to point out that 16 or 8% of patients in the 5-day arm were discharged prior to completing the full course, whereas 68 or 35% in the 10-day arm were discharged home prior to treatment completion. Overall, 86 or 44% of patients in the 10-day arm completed the full course of treatment, with a median duration of treatment of 9 days and interquartile range of 5 to 10. Patients in both groups were similar in age. There was a slightly higher proportion of male patients in the 10-day group, 60 versus 68%, and there was a significant difference in baseline clinical status, with the 10-day group having a higher proportion of patients in the high flow and mechanical ventilation or ECMO groups. The primary outcome for Simple 1 was day 14 clinical status as assessed by the 7-point ordinal scale on the left, which is similar to those used in the previous studies, except the severity ranking is flipped, meaning that death is category 1 and higher ordinal categories are better outcomes. The results of the primary outcome analysis did not show a significant difference between 5 and 10-day treatment durations via Wilcoxon-Rankin tests stratified by baseline clinical status. For secondary outcomes, there is no significant difference detected in either time to improvement, defined as a 2-point reduction in ordinal scale score, or time to recovery, defined as being a score of 6 or 7 between the two groups. In a post-hoc analysis, the authors examined if there was any benefit of 5 additional days of therapy, or in other words, doses 6 through 10, for patients grouped by their oxygen support requirements on day 5. For patients that required invasive mechanical ventilation at day 5, 17% of the 41 patients that received 5 additional days of therapy died by day 14, whereas 40% of the 25 patients who received no additional therapy died by day 14. An opposite trend in outcomes was observed for patients requiring high-flow oxygen support at day 5, with 15% death by day 14 in patients receiving an additional 5 days of therapy versus 10% in those that received no additional therapy. This analysis must be considered with several caveats, including it was conducted in a post-hoc fashion with small subgroups of an already relatively small sample, and there was inconsistent trends across groups, and I would caution readers against heavily relying on these data to inform allocation and treatment decisions. In the supplementary appendix, this figure was included highlighting day 14 clinical status for both treatment arms broken down by baseline clinical status. At the bottom of the figure in blue, we can see improvement rates for each baseline category, and since the study did not have a placebo arm, I've included the improvement rates from the placebo arm from the Act 1 trial to compare. In both the 5-day and 10-day arms, day 14 outcomes for invasive mechanical ventilation patients were worse than placebo in Act 1, but this was a relatively small group of patients. Improvement rates for the other groups in the 5-day were similar, if not slightly better, than the placebo arm in Act 1, but improvement was somewhat variable when comparing the 10-day group to the Act 1 placebo patients. So key take-home points from this study: no significant difference was detected in outcomes between 5 days and 10 days of therapy. Patients who were mechanically ventilated or on ECMO at day 5 and received an additional 5 days of therapy had a lower mortality rate by day 14 than those who received no additional therapy. But this was a small post-hoc analysis, and the trends for different groups were inconsistent. So this analysis should not be used for treatment decisions alone. This next trial, referred to as the Simple 2 or the Simple Moderate study, was a Gilead-sponsored trial comparing 10 versus 5 days of remdesivir to standard of care in hospitalized patients with COVID-19 meeting the definition for moderate disease, which was defined as pulmonary infiltrates and an oxygen saturation of greater than 94% on room air. Of the 612 patients screened, 596 were randomized. Notably, treatment was administered in an open-label fashion due to lack of sufficient amount of matching placebo. For the 10-day group, 193 patients initiated on therapy, 73 or 38% completed the full course, and the median duration of therapy was 6 days. For the 5-day group, 191 patients initiated therapy, 76% completed the full course, and the median duration was 5 days. For baseline characteristics, the patients were similar in age across groups, and about 60% of patients were male. Median duration of symptoms prior to randomization was 8 days for both Remdesivir arms and 9 days for the standard of care arm, which is similar to what has been seen in prior trials. For baseline clinical status, the majority of patients, 80 to 84%, were on room air but requiring medical care at baseline, followed by low-flow oxygen supplementation of 12 to 18%. Concomitant steroids were administered in 15 to 19% of patients. The primary endpoint was distribution of clinical status assessed on the 7-point ordinal scale on study day 11. The scale used in this trial is identical to the simple 1 severe scale, which is inverted from the one used in Act 1. Looking at the primary outcome, day 11 clinical status, there was a significantly higher odds of improvement on day 11 for the 5-day Remdesivir arm versus placebo. However, this significant improvement was not seen in the 10-day group. For day 14 clinical status, both Remdesivir arms demonstrated significantly or statistically significant improvement compared to the standard of care, and this was also observed for the 10-day group on day 28. It is important to note that non-primary analyses should be interpreted as exploratory due to the increased type 1 error risk for performing multiple comparisons without corrections. In this slow severity cohort, the prevention of disease progression is one of the most useful pieces of information. This figure depicts changes in clinical status from baseline at various time points, with green at the bottom showing improvement, gray in the middle for no change, and red at the top for worsening. We can see at day 14, the Remdesivir arm had a 6% lower proportion of patients worsening compared to standard of care, which narrowed to a 3 to 4% difference by day 28. It is important to consider that because these patients started with such low severity illness, the term worsened here could mean something as simple as initiating the patient on low-flow oxygen supplementation with nasal cannula. Overall, there were very low rates of poor outcomes in this study, with 1 to 2% mortality in the Remdesivir arms by day 28 versus 2% in the standard of care arm. Because the study was open-label due to the lack of matched placebo, the investigators attempted to assess if the intended duration of Remdesivir therapy influenced discharge decisions. This graph depicts the percentage of daily discharges over time between arms, and we can see that in both Remdesivir arms, there was an uptick in discharges the day following completion of therapy. This lends credence to the notion that the intended duration of therapy might have influenced the time to discharge and subsequently ordinal scale scores, but this analysis is not conclusive and should be interpreted cautiously. So key take-home points for Simple 2, the moderate trial. First, there was significant improvement in day 11 clinical status with 5 days of Remdesivir versus standard of care. There were lower disease progression with Remdesivir, a finding consistent with Act 1 data, and overall these patients had good outcomes with a low incidence of progression to advanced disease and low mortality overall. Secondly, no significant new safety signals were found in this study. Next up, we have the WHO-sponsored Solidarity trial published in the New England Journal of Medicine. Solidarity is an adaptive, randomized, open-label comparative study that set out to assess multiple potential therapeutic agents for COVID-19, including hydroxychloroquine, lopinavir-ritonavir, interferon beta-1 alpha, and remdesivir against local standard of care. The trial was conducted at 405 sites in 30 countries across all 6 WHO geographic regions and was designed to accommodate overstressed sites while testing multiple therapeutic options. Patients were assigned to one of the therapeutic agents that were available at their respective sites as long as there was no contraindication to therapy per treating provider. Control patients for a drug were patients that were assigned to standard of care at a time and place in which that drug was available. A total of 11,266 patients were randomized in the study, including about 2,700 patients in the Remdesivir arm or control. Of these patients, 2,743 were included in the intention to treat analysis for Remdesivir across from 2,708 patients in the control group. For baseline characteristics, the majority of patients were less than 70 years of age, making up 82% of the cohort. 63% were male, and around 2/3 required oxygen at study entry, compared to 24% not requiring oxygen and roughly 9% who were already ventilated at baseline. Almost 48% of patients in both arms received concomitant corticosteroids, and 2% received convalescent plasma. The primary endpoint was in-hospital mortality, with secondary endpoints assessing remdesivir's effect on progression to mechanical ventilation and hospital length of stay. For the primary endpoint, in the overall population, there was no difference between remdesivir and control on in-hospital mortality, with a non-significant rate ratio of 0.95 and a mortality rate of about 12.5% overall. We can see virtually identical Kaplan-Meier curves on the left, and on the right graph, we have mortality as assessed by baseline ventilation status. Not unexpectedly, remdesivir conferred no benefit in patients requiring mechanical ventilation at baseline, but additionally, there was no benefit seen in patients not ventilated at baseline either. The authors conducted a meta-analysis of mortality from randomized trials stratified by initial respiratory support requirements, which included data from Solidarity, Act 1, the severe COVID-19 trial conducted in Wuhan, and the Simple 2 trial. Data from Solidarity did not demonstrate significant benefit in any of the subgroups studied. However, the trial did combine patients requiring low-flow oxygen support with patients requiring high-flow oxygen, which is notable because the latter group did not appear to derive benefit in Act 1. In the meta-analysis of lower-risk groups, or those not requiring ventilation at baseline, there was a non-significant trend favoring remdesivir with a rate ratio of 0.8 and a 95% confidence interval of 0.63 to 1.01. Overall, remdesivir did not demonstrate a significant reduction in mortality in this meta-analysis. For secondary endpoints, remdesivir conferred no benefit in reducing hospital length of stay or progression to intubation in patients who were not ventilated at baseline. The proportion of patients remaining hospitalized in the remdesivir and standard of care arms at days 7, 14, and 21 are listed on the bottom left box, and at each time point there were more patients in the remdesivir arm remaining hospitalized. However, it is important to note that the open-label design of the trial could have influenced discharge decisions in clinically stable patients, as there was a trend towards delayed discharge in patients receiving active therapy courses lasting longer than 7 days like remdesivir. All in all, this was an overwhelmingly negative study for remdesivir. Key take-home points include that this trial was the largest trial completed to date studying remdesivir. The patient sample in the remdesivir analysis was 5-fold larger than that in Act 1 dataset, and enrolling sites were included from all 6 WHO regions, increasing the external validity of the trial results. The open-label design of the trial increases the risk of bias, but the clinically relevant endpoints of mortality and progression to intubation were unlikely to be impacted by this bias. No benefit was observed in the total population for mortality. However, there was a potential benefit in lower severity subgroups seen in the meta-analysis of randomized controlled trials, despite this finding not reaching statistical significance. Additionally, no benefit was seen in either duration of hospitalization or intubation rate. The second phase of the adaptive COVID treatment trial, or Act 2, sought to compare 14 days of baricitinib to placebo on top of a 10-day course of remdesivir in hospitalized patients with COVID-19 of varying degrees of severity. Patients in the baricitinib arm received 4 mg daily, or a reduced dose of 2 mg if their eGFR was less than 60 milliliters per minute. Notably, patients were excluded if they had a history of recent or recurrent VTE, neutropenia or lymphopenia, active serious non-COVID infection, or receipt of immunosuppressant agents at various time points prior to randomization. For allowance of concomitant medications, all patients received standard supportive care for their trial site. If a hospital had a written policy for the use of other treatments for COVID-19, patients could receive those treatments. Otherwise, these agents weren't permitted. This included corticosteroids, which were only permitted for standard indications such as adrenal insufficiency, asthma exacerbation, laryngeal edema, septic shock, and ARDS. 1,033 patients were stratified by study site and disease severity, similar to Act 1, and then randomized in a 1-to-1 fashion to either baricitinib or placebo, leaving 515 patients in the baricitinib arm across from 518 patients in the placebo. Patient characteristics were similar to those seen in Act 1, with a median age of 55 years, 63% male, and a median symptom onset of 8 days prior to randomization in both arms. Majority of patients carried a diagnosis of 2 or more comorbidities, with the most common being obesity, hypertension, and diabetes, in line with previous cohorts. Very few patients were classified as having an acquired or innate immune deficiency at approximately 3%. Post-randomization corticosteroid use occurred in 17% of the baricitinib arm and 20% of placebo. For baseline clinical status, over 50% of patients required low-flow oxygen supplementation, followed by 20% of patients requiring non-invasive ventilation or high-flow oxygen support. The primary outcome was time to clinical recovery, which was defined as category 1 through 3 on the 8-point ordinal scale on the right, identical to the one used in Act 1. These were patients that were discharged with or without limits on their activity, and patients that remained hospitalized but no longer receiving medical care, primarily kept inpatient for infection control purposes. For the primary outcome, there was a statistically significant reduction in time to clinical recovery with a median time of 7 days versus 8 days for baricitinib and placebo, respectively, corresponding to a rate ratio of 1.16. Despite this difference reaching statistical significance, it is not apparent that this is a clinically significant finding in light of the lack of benefit demonstrated in key secondary endpoints highlighted on the right. Median length of stay was 8 days in both arms, and there was no significant reduction in mortality endpoints observed both at 14 days or at final follow-up. There was a 5% lower rate of progression to mechanical ventilation or ECMO in the baricitinib arm of 10% versus 15% for placebo. I would like to point out that the width of confidence intervals has not been adjusted for multiplicity and as such should not be used to infer definitive treatment effects in these secondary analyses. Here we have recovery Kaplan-Meier curves broken down by patient baseline category. Looking at these figures, we can see that most subgroups have considerable overlap between both arms with no significant reduction in time to recovery observed. However, in the high-flow group, there was a larger effect seen, with median time to recovery being 10 days for baricitinib and 18 days for placebo. Median time to recovery could not be estimated for patients who were mechanically ventilated or receiving ECMO at baseline due to the protracted course of illness and potentially inadequate duration of follow-up. This figure is a graphical representation of day 15 clinical status broken down by baseline category. Categories are represented with the color spectrum, with the leftmost categories in shades of red representing worse outcomes, and conversely blue shades on the right representing better outcomes, similar to the graphic from Act 1. In the ambient air, low flow, and mechanical ventilation or ECMO groups, the proportion of patients that worsened from baseline to day 15 was essentially identical between arms. However, there was a difference seen in the patients requiring high flow supplementation at baseline, with about a 13% reduction in clinical worsening in the baricitinib arm compared to placebo. Baricitinib was well tolerated in the study compared to placebo, with higher rates of adverse events being observed in the placebo arm, which highlights the high morbidity of the underlying disease process. Notably, there were lower rates of serious and non-serious infectious infections in the baricitinib arm and comparable rates of venous thromboembolism events between arms. The authors note a higher incidence of infections in patients receiving corticosteroids, but this assessment was limited due to significant confounding by indication for corticosteroid recipients. In summary, patients receiving baricitinib had a statistically significant reduction in time to clinical recovery, but clinical significance of this reduction is not certain considering it was only a one-day reduction, which was primarily driven by oxygen status. No effect was seen on key secondary endpoints like length of stay, which was identical between arms, or mortality. The potential role for baricitinib might be in prevention of disease progression as seen in patients receiving high-flow oxygen at baseline, and the lower overall rate of new mechanical ventilation or ECMO. This will be further investigated in Act 4, which will compare baricitinib to dexamethasone on a remdesivir backbone. For safety, baricitinib was well tolerated overall and had a lower adverse event rate compared to the placebo arm, and no increased rates of venous thromboembolism or infectious complications was seen. This next study, entitled the PINETREE study, was conducted to assess if early outpatient administration of remdesivir would be effective in preventing disease progression. Patients were eligible if they were 12 years or older, with at least one pre-existing risk factor for severe COVID, listed on the right-hand side of the slide, or if they were 60 years and older, irrespective of risk factors. Eligible patients had at least one symptom of COVID-19 with onset within 7 days before randomization, and a PCR confirmation within 4 days before randomization. Patients were ineligible if they were expected to require supplemental oxygen or hospitalization at the time of screening, or if they had previously been hospitalized or treated for COVID-19. Notably, they were excluded if they were vaccinated against COVID-19. The trial was conducted between September 2020 and April 2021 at outpatient infusion facilities and skilled nursing facilities, with some home infusion as well. Patients were randomized 1-to-1 to either 3 days of remdesivir, consisting of 200 milligrams on day 1, followed by 100 milligrams daily for 2 days, or placebo. Randomization was stratified based on age, residence in skilled nursing facilities, and country. For the sample, 630 patients were screened and 584 patients were randomized in equal parts to remdesivir or placebo, resulting in 292 patients randomized to each arm. 279 patients in the remdesivir arm and 283 in the placebo arm were included in the efficacy and safety analyses. Additionally, the trial concluded before target enrollment was achieved during a time of decreasing caseloads and ethical concerns of randomization to placebo, with the availability of emergency use therapeutics like monoclonal antibodies and increase vaccination in high-risk persons. Patient characteristics were similar between groups with mean age of 50 years, slightly less than half of patients being female sex, and average BMI of 31. Median time from symptom onset in both groups was 5 days, and median time from PCR positive test was 2 days. For comorbidities, the most common was diabetes, which was present in 61% of patients, followed by obesity, hypertension, and chronic lung disease. Patients with immunocompromising conditions were largely underrepresented in this cohort, comprising 4% of the sample, and patients with current cancer were 5%. For outcomes, the primary outcome was day 28 COVID-related hospitalization or all-cause mortality. Secondary outcomes included 14 and 28-day rates of COVID-19 associated medically attended visits or death, time-weighted nasopharyngeal change in viral load from baseline to day 7, and time to mild or absent symptoms as compared to those at baseline using the FluPro symptom questionnaire. For the primary outcome, there was a statistically significant reduction in COVID-19 attributed hospitalization by 28 days, which occurred in 0.7% and 5.3% in the Remdesivir and placebo arms respectively, corresponding to a hazard ratio of 0.13. No patient in either arm died by day 28. For secondary outcomes, there was a significant reduction observed in COVID-19 associated medically attended visits by 14 days, occurring in 0.8% and 7.9% in the Remdesivir and placebo arms respectively, translating to a hazard ratio of 0.1, with a similar difference being observed in the day 28 outcomes as well. For the day 14 symptom alleviation, there was a significantly higher proportion of patients reporting alleviation of symptoms by day 14, with 36% versus 20% in the Remdesivir and placebo arms respectively. For the virologic outcomes, the mean baseline nasopharyngeal viral load at baseline was 6.29 log 10 copies per milliliter. There was no difference in the time-weighted average change in viral load from baseline to day 7 between Remdesivir and placebo, which is consistent with findings from the previous trial conducted in Wuhan by Wang and colleagues, which also did not observe a significant difference in viral load reduction from Remdesivir therapy. So in summary, patients receiving 3 days of outpatient Remdesivir had a statistically significant reduction in day 28 COVID-19 attributed hospitalizations in patients with mild to moderate infection with risk factors for progression to severe disease. This supports the role for early administration of antiviral therapies and can serve as an alternative to spike protein targeted therapies like monoclonal antibodies in variants with predicted resistance due to highly conserved nature of the target for Remdesivir, which is the NSP12 polymerase. However, I think it is important to note that the effect size would likely be diminished in lower risk populations like patients that have been fully vaccinated or those without risk factors for disease progression. This is a particularly important consideration given how challenging it is to implement 3-day courses of outpatient Remdesivir. Additionally, there was an underrepresentation of patients with immune-compromising conditions in this cohort, so these findings are not generalizable to these populations necessarily. There was a significantly higher proportion of patients reporting symptom resolution by day 14 with Remdesivir, but this did not translate into observable reductions of viral load compared to placebo. No new safety signals were observed with Remdesivir therapy, and it was well tolerated overall. Here's a look at the available finalized results for inpatient trials. And in summation, Remdesivir significantly reduces time to clinical recovery. This benefit is most apparent in patients requiring low-flow oxygen supplementation, but a modest benefit has been observed in patients with moderate disease. No mortality benefit has been observed in the overall patient population in trials to date, and further refinement of meta-analyses are required to explore the possible benefit in lower risk groups, in particular patients requiring low-flow oxygen supplementation. The sum total of the data are not definitively supportive of a hard 10-day cutoff for symptom onset. However, it is plausible that earlier therapy confers additional benefit for antivirals. Additionally, in patients who do derive benefit from therapy, it appears that 5 days is equally efficacious as 10 days of therapy. Early outpatient therapy significantly reduces COVID-19 related hospitalizations. However, this data is in unvaccinated patients who are symptomatic and at risk for severe disease progression. Lastly, serious and non-serious adverse events have been observed at similar or lower rates than placebo in our controlled trials, confirming that remdesivir is well tolerated. Thank you for your attention, and please do not hesitate to reach out for any questions that you might have.